welcome to this amazing session. We are going to talk about how to implement value-based healthcare project into different approaches. This session is brought to you by Roche, and we have with us Marta Suarez and Florian. We are going, as the name says everything, we are going to talk about value-based healthcare and two experiences regarding the implementation of value-based healthcare in two different hospitals. One hospital, the Instituto de Oncologia, Português de Oncologia in Porto, and the University Hospital from Basel, Switzerland. Thank you so much, Marta and Florian, to be with us. Marta is also the clinical director of the Oncology Institute in Porto, and she is going to show us this project that was focused on lung cancer, that is FAROL. The translation in English is LightHouse, and this is a partnership between the Oncology Institute in Porto, Portuguese Association of Hospital Managers, and Roche, and aims to develop a model of lung cancer financing. Also, we have Florian that will talk about implementation of a partnership in the University Hospital in Basel. This session we will have 75 minutes. Our speakers will do a brief presentation, 20 minutes presentation, and then we will have the time to discuss with you and among ourselves. And for that, for you, I encourage you to use our chat box. You have it on your right of your screen, and you can comment the session during the session and make some questions and remarks about the two presentations. At the end, I will select the questions and I will bring them to the screen, and we can answer them and discuss them. So thank you so much to be with us this afternoon in this EMA 2021 conference from the lights of Lisbon. As you can see in my back, it is starting to get dark. Marta, please, the floor is yours.
Good afternoon, everyone, and thank you to the committee, the organizing committee and Roche for this kind of invitation. So I will try to share my screen. Sorry. So I'm going to share with you the experience of the Portuguese Institute of Oncology.
Marta, sorry, you're sharing still the folder, not the presentation. I think you selected the file.
Sorry. And now?
Try again.
Is it okay?
No, try again. Try to stop sharing and resharing. Otherwise, I have your presentation. I can do it for you.
Okay. No, I'm not. What do you see?
We saw your entire screen. If you want, I can share your presentation.
Yeah, it's better, if you don't mind. Okay, now everyone can see. Sorry, go back, yeah. So cancer is one of the highest causes of global health, and unfortunately is increasing, leading to a significant economic burden and cancer is the leading cause of death, and is one of the major impacts of economic loss for the death of cancer. Next slide, please. Next slide. Oh, no, okay, it's okay. Lung cancer leads the causes of cancer death, and has been related to a significant daily loss over the past years. Is the top cause of daily loss linked to cancer, and in Portugal it has an incidence in cases of cancer deaths of 19.4%, and the 5-year survival rate of lung cancer is 15.7%. Next slide, please. In fact, lung cancer survival rates drops as disease progresses. So we have an urgent need to get an early diagnosis of this disease, so that we can have a solid management of these patients. Because if we can catch this disease to the early stages, we have a survival rate of 92%. At 5 years, and in the stage 4, it's only 10%. Next slide. The adoption of value-based frameworks will support the improvement of these health results. If we can measure the outcomes well, we can improve and have a critical step for this implementation. Value-based healthcare is all about creating value for all the health system stakeholders, improving the relationship between the quality of care and the costs required to do that. We have to improve the outcomes, and the starting point is to measure and improve the health results that matter most for the patient condition. And if we do that, and we can also reduce the costs, we can increase that value. Next slide, please. In IPO Porto, we have partnered with several institutions to develop a value-based healthcare pilot project in lung cancer, named the project FAROL. That's in English, it's LightHouse project, and we partnered with Allcan and ISHAM for the collecting of PROMs, and with the Portuguese all administrations, IPAH and Roche, to do this project. Next slide, please. This project required a lot of work, and we had initially to define the most accurate care pathway, and then to enable the cost assessment and the outcomes measurement. For that, in the beginning, we choose lung cancer as the main pathology to do this work, and we then had to define the care delivery value chain. We had to map all the process of the lung cancer pathway in our institution, so that we could develop the process map of all the activities in patient care delivery. We had lots of interviews with all the personnel that was involved in the care of these lung cancer patients, from the administrative to the clinicians to the nurses, and all the staff, and we mapped this lung cancer pathway. Then to the lung cancer cost assessment per patient, we used a kind of technology, the time-driven activity-based cost, whenever possible. And when we couldn't do this kind of technology, we used the degree price. This was also a process that was that involved many work from lots of people, and we tried to obtain the time estimates for each procedure, the activity of that kind of resource. Sometimes we had those times collected in the process of the patients. Some other activities we had to measure those times in order to get the time exactly collected. Then we estimated the cost of that supplying using the resources and those data that we had for that kind of activity. We estimated each resource capacity, calculating the capacity cost rate, and then using all this information, we calculated the total care for patients. And then for the outcome measurement, we tried to use the standard set definition, implementation, and analysis that I will talk a little bit later. And when we had the data collection, compilation, and analysis of those outcomes measurements. Next slide, please. Next slide. Okay. So after collecting all this information, we achieved some results for the lung cancer assessment per patient. In Portugal, we have a funding from the Portuguese government for the patient with lung cancer, and in the first year, they pay us 1,400 euros per patient in the first year, and 366 euros per patient in the second year. Our results for the costs for the lung patient in the first year was 300 euros, and in the second year was 1,200 euros. The distribution of these kinds of results in terms of costs were also divided by the kind of treatment that we did to the patient. And in the first year, we have costs of pharmacological treatment lower than in the second year, because normally in the first year we have some patients that are in the initial stages and that do surgery and radiotherapy, and in the second year the costs of the pharmacological treatment are much higher because normally there are more patients in advanced stages that where the medications are much that costs more to the institution. The distribution by stages is also the ones that we are used to see, and the patients that are present in stage 4 costs more because the pharmacological treatment is more intense in this kind of patients. Next slide, please. Regarding the outcomes measurement, the initial thing that we wanted to collect were the outcomes measurement that were given by the ISHM standard sets, where they collected report PROMs using the quality of life questionnaires from the ERTC. But the majority of our patients didn't have those kind of recording of PROMs. We have only started to collect PROMs prospectively in our institutions in the last year, so we didn't have those kind of data for this project, and we decided to collect other other outcomes measurements, and we decided to have other kinds of indicators, and we selected the survival rate in the first and second year, the time between diagnosis and treatment initiations, and the share of patients that were under pharmacological treatment in the last 30 days of life, and the days spent in the hospital in the last 30 days of life, and also the share of unplanned hospitalizations and the share of unplanned appointments. Next slide, please. With those kinds of outcomes measurements, we have discovered some things that then we had to improve. One of those things was the time between diagnosis and treatment initiation in days, and we have discovered that some patients in the first stages were having a big delay within the diagnosis and initiation of treatment, and we have improved these kinds of circuits. And nowadays we don't have 70 days for the treatment initiation in stage 1 and 2. We have achieved this time is now about 30 days. So with these findings, we managed to improve the outcomes of our patients. Next slide, please. With this project, we have added value to the institution. We have learned and we implemented some measures to improve the outcomes. Selected outcomes comprise relevant indicators for both clinical practice and for the patients. One of those examples is the quality of life indicators that we measured. The data necessary to calculate the selected indicators is gathered systematically and is easy to update in our kind of registry. And the selected outcomes that we had to select can be applied not only to lung cancer but to other kinds of pathologies. The measuring of quality of care will lead to a process of continuous improvement, and we hope that measuring the quality of care and analyzing the results will allow the structuring of alternative hospital funding model that we hope that will lead to incentive towards therapeutic care and procedure excellence. Of course, we have some implementation hurdles and limitations, and one of them was that ISHM lung cancer standard is not systematically collected in Portuguese hospitals. Even in our institution was a little bit difficult to implement. And PROM's collection has only started recently, as I told you before, in IPO Porto, but we hope to have this kind of collection in all kinds of malignancies, so that we can have data that will help the clinicians to select better the treatments that they are doing. And there should be a greater focus on incentive towards the outcomes collection and measurement and the structuring of continuous improvement process. Next slide, please. So we were lucky in our hospitals, and we have leadership that will help us to create this process in a success form. We have a healthcare professional involvement that will help us, and we have an IT system that also will help us to improve this kind of technology. Next slide, please. This project has several benefits for better understanding of the patient pathway, and we hope to help us to have a financial efficiency and quality of care improvement. And the main benefits of this project for us divided in 3 areas. In the patient pathway design, we could be able to understand better the clinical pathway of the patient, the initial assessment and the continuous improvement of patient care and clinical practice, and the patient pathway standardization will help us also to improve this pathway design. In order about the costing analysis, we were able to have a costing of lung cancer treatment pathway activities that were otherwise not, we were not able to have the right price for the treatment of these patients. We could have a variability analysis of the patient pathway and the treatment costs. We had a better understanding of the real cost of lung cancer treatment, and that will allow us to understand how hospitals can be more financially efficient. And we will be able in the future to benchmark real costs with other institutions and with the comprehensive price that is currently set by our payers. We hope that we can measure patient-valued outcomes and not only the value for the institution. We hope that we can improve care quality measurements and to international benchmark, and measuring care quality and how outcomes will enable us to identify the best incentive-based funding models linked to therapeutic and care and procedure excellence. And so thank you so much for your attention.
Thank you, Marta, for this amazing presentation. I will encourage you to, we have some comments already in our chat box. I will continue to encourage all the delegates to make their comments, their questions. But now the time is to Florian. Florian, it's now up to you. You are an experienced quality manager, previous cardiac surgeon, dedicated now to quality management. You have the experience of implementing PROMs for more than 20 diseases. The floor is yours.
Yes, thank you very much for your introductory words. And now I will try to share my screen. I hope that it will work. And now you should see my screen. Well, thank you also to Marta. I'm always really deeply impressed about your exciting data from the denominator side of the value equation. Now, we at Basel University, we are one of 5 university hospitals in Switzerland. We are coming from the other side of the value equation, And in a brief presentation, I would like to give you an overview. And at the end, you should also understand why we are in a very good partnership with Roche. Well, I'm head of quality management and value-based healthcare here at Basel University Hospital under the auspices of the medical direction. Well, now, thanks also for the organizers to invite me to present here a little bit an overview about our experience. Well, the beginning for us was this mandatory question. I think it's so important, always never forget the questions, what do patients really want? And I think this is a simple but also not easy to fulfill answer of Michael Porter, who together with Ms. Theisberg had the opportunity to write the book about value-based healthcare, redefining healthcare. And he put it in one sentence: achieving good patient health outcomes is the fundamental purpose of healthcare. And it sounds so easy, but in reality, it's not as easy, because what are the questions the patients want to have answered? What do they want to know? And I think just in the surrounding of oncologic diseases, the first time they want to know something about survival, their disease progress, the treatment effectiveness. But also important are the following things. They have to get information about their pathways, their treatment pathways, and in the pathways about the waiting time for decision, and also waiting time for treatment. And at the next time, what does my personal treatment has for consequences for my quality of life? And that is a point where we need the data of PROMs. The PROMs, the patient-reported outcome measurements, because they give us very important insights about side effects. They give us data for symptom control, and the patients also want to have information about support groups, and they need quite good digital tools. And at least there are also social variables, and as a doctor, we sometimes forget about those implications for the family, for the job, and also for the costs of therapy. And what are the answers of our healthcare system? Well, we have different answers. We have some words like personalized or individualized medicine. We have something like patient empowerment. We have patient centering. We have lean management. We have also big data and artificial intelligence to work with this data. But are these things, which are all for themselves, are quite important, but I think it's not enough for our patients. The question still is, what do we really need? And to my mind, to our mind at Basel University Hospital, we need a simple change in our mindset. And despite, as a highly industrialized Western country, and despite the fact that we are investing a lot of money in our healthcare system, are we doing it in a good way, in a good quality? And I think the answer, sometimes. And 2 years ago, there was this paper on the left side, enhancing the quality and safety of Swiss healthcare. And what did we find? We found that we have only a very small number of quality indicators which give us a picture for the whole Swiss healthcare system. And if you look on these data on the right side, which was just published some weeks ago by the Commonwealth Fund, in an overall ranking under the 10 most rich countries all over the world, we were nearly at the last place in the overall ranking. And so you can see there are still a lot of questions open and a lot of things to do. So that is a new mindset. That's just mentioned redefining healthcare, and the basis, what Marta already told us, is the value equation. The value equation in the nominator side with the patient-reported outcomes, but this is not the theme of today, the patient experience, and on the denominator side, the costs. And we heard a lot of things about the denominator side by Marta, and I'm coming back to the nominator side, to the PROMs. And what was the source? Why did we implement PROMs? And that's a question And the answers for these questions, they are so important for everybody who wants to start with such a program. And if you start with PROMs, you not necessarily have to implement value-based healthcare. It's enough to start with PROMs because they alone have a lot of worth for the patients. If you want to have a picture of the whole value equation, okay, you have to do a little bit more to see the whole picture of value-based healthcare. Okay. Why implementing PROMs? We want to realize the treatment value and the quality from the patient's point of view. This is a part we don't know enough about. And based on these data in future, we want to make patient-centered treatment decisions because we want to focus on those values which are really essential for our patients. And on the right side, there is an example of an item standard set of the dimensions of the items we ask our patients. And on the upper side, you see those things which are evidence-based medicine like survival, recurrence-free survival, reoperation due to positive margins, or acute complications of treatment. These are CROMs, clinician-reported outcome measurements. But the other items, they are much more important for the patients, for the women under treatment for breast cancer. Well, what about depression, pain, fatigue? The fatigue syndrome is so important in breast surgery and in breast cancer. What about my body image? What happens if I look on my reconstructed breast when I'm standing in front of the mirror? And what does that mean for my role model in family, the treatment? And what does these things mean for my intimacy, for my sexual life, for my quality of life? These are the questions which are important for daily life. And the same you can see in men under treatment for prostate cancer. If I have to resect my prostate due to prostate cancer, I want to know, what about urinary incontinence? What about sexual or erectile dysfunction and my vitality? Because every urology surgeon in all over Europe, they have a 5-year overall survival higher than 90%. But there are differences. And I think this is such an important slide. This is what I said to you, the 5-year survival. These are data from Germany. On the left column and on the right column, the Martini Clinic. That's a department of the Hamburg University Hospital Eppendorf. It's one hospital only for the treatment of prostate cancer. And there are the differences on the right side. The differences are in those things which really matters to patients. The 1-year incontinence rate, or also the 1-year severe erectile dysfunction. And that's the answer why we need PROMs, because we need those data. And if I have prostate cancer and I have to resect it, I would know where to go, to the Martini Clinic or to another clinic who has these data. And you only have these data if you have PROMs. And especially in the oncologic area, importance of PROMs is much higher. As you see in this curve, patients after breast cancer who are part of a patient-reported symptom monitoring, they have a better survival. Why? Not only because they fill out PROMs. No, the answer is because on the other side, on the hospital side, there are experts, doctors or specialized nurses who look on the data, look on your answers, the patient answers, and if something is going in a wrong way for the patient, they take a call to the patient, they bring them back to hospital, they intensify the diagnostic, and that's no surprise, they find patients with recurrence, with metastasis, and they can also intensify the therapy. And that's why patients who are part of a patient-reported symptom monitoring have a better survival at the end of the day. And coming back to lung cancer, these are also data from Sloan Kettering Memorial Cancer Center in New York, published 2 years ago. They could replicate these experiences with breast cancer in lung cancer. And they're also very impressive. The survival in patients who are part of a PROM program, they have a better survival if there is on the other side somebody who works with the data and who speaks with the data with the patient, or about the data with the patient. Well, This is the status quo, what we are doing in Basel since last quarter of 2017. Up to now, we have implemented around 20 PROM sets. Most of them were IGEM standard set, disease-specific standard sets. And in areas where there were no IGEM standard sets available, we developed with the experts, especially in orthopedics and traumatology, some more PROM sets. So we have some with currently no inclusions. We had to learn some lessons. One lesson is if you do not have a physician leader at the beginning of such a program, it's not easy. We had to learn that especially in acute situations like stroke, it's not the first interest of a patient to fill out a questionnaire if he comes with a stroke to hospital, and some other things. Up to now, we could include more than 5,150 patients into PROMs. And I think to answer the question again, why do we do it? We have two targets. We can use those data on an individual level and on a group level. And there you see our specialized breast care nurses. And that's why you not only need doctors, you also need active, interested nurses. And they are the personnel who work with the PROM data of breast cancer patients. On the right side, you see a picture of our software platform we use. It's a heartbeat software, but there are on the market different other hospitals. It's very easy to interpret. On one view, you see how the position of the patient is. The smaller and greener the dot is, as better it is, and the more red and the more big, there is a problem. And there you see satisfaction with the breast. That's on the fourth row from the upper side. You see on the left side, there is a baseline just before therapy, after diagnosis. And the first or the second dot is after breast surgical intervention. And it's understandable why satisfaction with breast just 30 days after intervention or the sexual well-being on the lowest row is not very good. But at the end of the day, after half a year and 1 year later, the result is quite good. And now we can really see that the patients are doing well. And this is always a slide, a picture out of our heartbeat software where you can see all the different items which are asked around breast cancer. And what we had learned is that intimate topics which were asked to the patients before the consultation by the doctor made it easier to them to discuss about these things, about intimate questions, about sexual well-being and those things which are really important for daily life. And it led to a more trustful doctor-patient relationship, and it brought a closer involvement of the breast care nurses who really have the direct contact with the patients in the treatment pathway, because it broadened their range of tasks and it increased their work attractiveness as a side effect. Well, on the group level, we have here the data in an international benchmark with really well-known international clinics from all over the world. And why is it so interesting? Because only hospitals who collect PROM data have those data to compare their results in a benchmarking, in international benchmarking. And I think every CEO of a hospital or every head in this example of our breast cancer unit loves this data. He sees that the patients are really doing good and we are delivering good quality of care. And we have a good patient satisfaction and we could go in an international benchmarking. And that is also marketing that's important. Now, coming to the answer of the question, why are we in a private-public partnership with Roche? We had the challenging situation that always 3 departments are involved in the complex treatment pathway of lung cancer. It's the Department of Oncology, Thoracic Surgery, and Nuclear Medicine. And there are minimum 3 different pathways, and everybody who is a little bit familiar with treatment of lung cancer knows that the patient is going from one pathway to the other and in different directions. And that's the cause why there was the need for cross-functional personnel. It's not easy to implement the lung cancer IGEM standard set. So Yet on the other side, we have a common interest. We have both partners in the cooperation between pharma and university hospital, a common interest what really matters in daily life for our patients. And based on this question, what have these for consequences for the future of healthcare? So at least from our point of view, it's a real win-win-win situation for patients, our hospital, and Roche. And what are we doing now in detail? We are looking on the pathways. We are looking on our processes, and everybody knows who is working with quality and management in hospital. If you look on processes, you will find waste and you will find areas to become better. Well, and the second step, we want to have a picture of the whole value equation. I think there's a little bit experience in PROMs in our hospital, but there is much more experience, and that's why it's so important for us to get the contact to Marta, to Porto. We want to learn. We want to learn how do they do TDABC and these things, how they collect which data, which financial data. And we just started with this point. And out of these data from example patients, now we are able to look which parts of treatment are responsible for which costs. And we can look for in the year manner, we can also look on the monthly basis. And that's the future of our project. We have to bring together on a patient level and also on aggregated patient group level the PROM data with the financial data to see if the value equation, which was originally made for the US market, is also working on the European market. And at least, yes, we want to crack the cost of patient care. And that's the basis of our partnership between Pharma Roche and Basel University Hospital. And these at least are our both future visions. We want to expand the classic triangle between patient, service provider, and health insurer by integrating pharma and medtech industry and policymakers for a common alliance, for an evolution from patient-centeredness to a real partnership where we speak first to patients and to each other as equals, with more value in mind for the healthcare system. And that's our starting point, the starting point for the power of changing our minds. And this starts with taking action. And that's why we're in such a partnership. So at this point, I hope it was not too much information, only a small overview about what we are doing. Thank you for your attention.
Thank you so much, Florian. It was a really insightful presentation. I believe even in our participants, we have lots of questions. I think everyone is quite excited. We always talk about value-based healthcare. It's not every day that we have two implementers, you in Switzerland and Marta in Portugal. And I will start with the first question that we have here. It is from João Frutuoso. He was asking, I believe this one is a little bit more simpler, is asking if the data that you are collecting are part of the ISHM standard set. I believe so. Can you, Marta or Florian, to present it? How do you select this this model? How do you go through for the ISHM standard set?
Well, we collect all the data and all scores from the ISHM standard set, but we saw that these are really a lot of questions, especially after they ISHM renovated the standard set and now they use the EORTC LC 29 instead of 13. So, and the number is always the count for the questions, and the question count is really high. Patients need about 15 up to 20 minutes to answer all these questions, and that's an important point of concern sometimes when you implement such a standard set. For me, I think that was another lesson to learn. It's not so important which tool you use. There are different tools. You don't need always to use an item standard sets with all the different scores. The only thing is, if you want to make a benchmarking, that's not really easy, then you should be sure that your partners are using the same standard set and they ask the questions at the same time points. But there are also good arguments, especially in such a very heavy disease like lung cancer, perhaps to shorten the questionnaire.
Marta, in your case, you are using also the ISHM standard set. Did you shorten the questionnaire? What was the experience?
In terms of questionnaires, we are using the same quality of life questionnaires as they use in ISHM. Yes, we are now collecting them prospectively in our patients, not only lung cancer, but we are trying to expand to other kinds of cancers.
No, that's great. Regarding actually, it's something that is quite cross challenging. It's how can we involve healthcare professionals on collecting PROMs? And we will discuss later the costs, but for the PROMs, how can we engage? You know that we have medical doctors that are overwhelmed. We have nurses that are overwhelmed. How can we engage them in this activity that probably in their mind initially it's not on their core area of work? I don't know, Marta, if you want to go first, or Florian,
yeah,
feel free.
I can go first. Indeed, it's difficult because all healthcare professionals are very busy. But in our institution, we try to create a place with 2 nurses that collect and help patients to fill the forms, and we schedule a meeting for them in a certain time point in time, and they go there. They collect the questionnaire in an iPad. And then we work the results later. So we have 2 nurses that only do this kind of work. Otherwise, it was difficult to collect. Initially, we had the patients in IPO Porto. We are organized in clinics. We have the lung clinic, the breast clinic, and others. And the patients were getting to the clinics to fulfill the questionnaires, but this was not working. And so we decided to get a special place where they can go to collect only the PROMs. And it was easier to engage the patients and the staff to do that.
Oh, great. Florian, what was your experience? You have more than 20 diseases where you are collecting PROMs.
Well, I think just at the beginning, you need really dedicated personnel to implement PROMs. And I can only repeat it. Just at the beginning, you need a committed physician leader for that. And we were lucky that we had Professor Weber, our breast surgeon, who was for educational purposes at the Sloan Kettering Memorial Cancer Center in New York, where he got first contact with PROMs, and he was already committed when he came back to Basel. And that was a lucky point when he met our Chief Medical Officer, Christoph Meyer, who was committed about the ideas of value-based healthcare. And those 2 together were the perfect start for the project. And to be honest, it took us nearly 2 years after the beginning at the end of 2017. And from then on, we only implement PROMs in those areas or clinics where doctors or nurses are coming to us, the quality departments, they say, we want to have PROMs. I think if you try to do it in a top-down project, it could fail. So we have it now. We have both top-down and bottom-up now. And now, as it is a more bottom-up project, this is more successful. So at the beginning, to be honest, you have to invest in a in a suitable platform, an IT platform, and you have to commit doctors, nurses, and administrative personnel, because at the beginning it's a little bit more work, yes. But at the end, the patient wins. You can integrate the data into the patient pathway. That is the second important step that's not realized in all our PROMs, but that's the next thing. And if you want to have committed patients, you have to show them that you work with those data. You have to unmute yourself.
No, I was. You don't have any session like this with someone that is muted. But mostly, this is quite interesting. And for the implementation phase, are you giving also some feedback to patients, to healthcare professionals as a routine from the data that you are collecting? Mostly because I feel if they are collecting all this data, even patients or healthcare professionals, if they don't get this feedback from the data that you are collecting, they will probably feel that the work is not worth it. What is the process that you are implementing, Florian, in Basel?
I think there are two steps. One step is to explain them the idea of value-based healthcare. And the second step is how they can work with the ideal IT platform. And every click for a doctor he has to do in an additional way is a click too much. And that's the second thing. You have to integrate the IT platform into the ecosystem, the IT ecosystem of your hospital. And when they have the data and when they see the data, they become more and more committed to it. But it's always mandatory that they don't use or misuse their time only for searching of data. But when they understand that they can spare a lot of time when they use the PROM data, because the PROM answers of the patient, if they are filled out just before the consultation, they are part of the normal doctor-patient talk. And the doctor could concentrate on those areas where are problems, where is the need for action. And that's win-win for both.
Thank you. And Marta, in the case of the Oncology Institute in Porto, what is the process? The data that you are collecting, you are giving the feedback to healthcare professionals and to patients, or do you plan to do it?
We plan to do it. We are now in the process of getting the report on time to the clinician so that he can use that kind of information. But we are only trying to implement that. We don't give those data right now to the clinicians.
I know that in the case of the project in Porto, one of the objectives was to influence also the payer to at least to revise the tariff that was being applied to lung cancer patients, because the payment is directly it's patient-based mostly. So mostly the Oncology Institute receives an amount per each lung cancer patient that is treating. In the case of Basel, Florian, what was how you are paid at this moment, and how can you influence the model of payments, the payment model that is being applied to the hospital?
Well, our private-public partnership with Roche was the first step to look also on the denominator side of the value equation. And we are now collecting from all lung cancer patients all financial data we collect through their stay in hospital, with the goal to develop value-based costing, pricing, and reimbursement procedures. And we are in parallel have two other projects with insurance companies in other areas from orthopedics and from urology, where we have PROMs to find new tariff models. And well, we are not as far as Marta and our colleagues in Porto are, but the goal has to be to look if Michael Porter's value equation really works. And in theory, it works that you can look for better quality if you collect PROMs, if you look on the quality of treatment, and you can, on the same time, you can lower the costs you have for the system. But I think that's, for me, a very important question. If I go to the head of the financial department and say, okay, we want to reduce costs, he says to me, okay, you're crazy. At the end of the year, I want to have more money because we have, yes, we are like industry sometimes. I think that's the wrong way to see it, but that's the truth. So at the end of the day, we have to see if we can create an increase in quality and lower our costs. And at the end of the day, the patient has a better quality treatment and the hospital has a positive return on investment. And the other side of the partnership, why is it negative if the pharma industry, which is really important for Switzerland too, has a return of investment too? Unmute yourself, please.
Second time. What is the payment model that you are having now in the Basel for lung cancer patients?
Well, it's in the moment just fee for service.
Okay. So that will be a change to move for something like a bundle payment per patient.
I think the problem is in the most Western Europe healthcare systems that we have a fragmented system. And we have not altogether hospitals and rehabilitation clinics, for example, they are all separated. And until this is separated and you don't have PROMs as a tool, which is an overarching project about the acute clinic hospitals and the rehabilitation phase, it's impossible to talk about bundled payments. You have to compare your data, and we want to find insights because we cooperate with insurance companies too, because they have the data from the pre-hospital phase, the hospital phase, we have those data by ourselves, but the insurance companies, they have also the data from the post-hospital phase, from the rehabilitation phase, and we try to think in this direction in the future to have or to go in the direction of bundled payments.
No, that's quite relevant because mostly what we want is this continuum of care, and this fragmentation will, of course, it will not allow it. There is a striking question here in our comments. I believe that Florian and Marta, you can answer to it regarding the partnership with Roche in your projects. Do you have any conflict of interests, or this is quite clear, the development of this partnership? I will start with Florian and I will go to Marta.
To my mind, I'm really sure about that, there is no conflict of interest. Why should there be a conflict of interest? Roche don't get any patient data. We have a third party for analyzing all the data, and the third party is the University of Basel, and they will analyze the data. And at the end, we want to see the results, and we share the results, and we want to learn together. And it was so important for us as a hospital. It was a really new explorative way to learn together. And we could, we have a lot of advantages about this partnership. I would not have the possibility to talk about these things without Roche today in this session. And we got contacts over Roche to Porto, that there were different hospitals all over the world which are on the same direction, which are doing or have the same goals, but have different approaches. And it's so important to learn from each other. And I think those things which were brought into the partnership by Roche, and on the other side, the things we bring to the partnership, these things together, this information, this learning potential is, I'm really committed to that, is really high. And so to my opinion, there is no problem in such a private-public partnership. But what's your opinion, Marta?
Well, I think the same way. The hospital has a lot to gain with this partnership because it has enabled us to have the partnership with IPO to help us to analyze our data. It's difficult for the institutions to have some kind of resources to help us to analyze the data and to IQVIA helped us to create this system to analyze the data that we had. And all the data was anonymized and it was analyzed with the people of our institution, and we only have shared the anonymized data with the other partners in this project. And so I think that this partnership was very helpful for us, because otherwise we wouldn't be able to do this kind of time-driven, activity-based cost kind of analyze without their help.
No, thank you so much, Marta. I think this is quite important, Florian, because this is quite important if the other participants want to engage or develop this kind of projects. It is clear that if you have the involvement of third parties, you can bring third parties involved, academic institutions, analysts, pharma organizations. They can help on implementing this, and you need to be sure, of course, that everyone is aligned with the objectives of the project. And this ecosystem, this big ecosystem that is healthcare, it is relevant to engage with every partner. And even when Florian was talking about this fragmentation of care between health providers, we really need to bring everyone on board to implement these projects. Going a little bit back, I know that our participants want to know what are the ingredients to start, besides courage, what are the ingredients to start a value-based healthcare project like yours? I will start with Florian.
Well, you need commitment of your partners, and that was committed doctors and convinced about the goal of the project. They have to trust that we want to create more value for our patients, and it was so important to not only as a top-down project to tell them, come on, you have to implement PROMs in your area. The truth is that you have to to communicate always the idea behind collecting PROMs. And as I said before, collecting PROMs and working with PROMs is quite a good thing. You can do a lot of things. You can do research, you can publish with PROMs, you can make quality management, you can increase your quality with PROMs. Everything's okay. But it's only perfect if you use them in the whole picture of value-based healthcare, because you want to create more value for patients, more value for the hospital, and more value for the healthcare system at all, because you want to lower the costs and you want to increase the quality. And that's why all these things, they belong together. And you have to talk about that, and you have to convince to your partners that they will be a part of the project. And I think the beginning is the much hardest step. It's always, if you go on the journey, the first step is the hardest one. But if you are just on the journey, you will see more and more partners. And now we have the lucky situation that it's a really well-known project in the Basel area. We have put the value-based healthcare idea into the strategy of our hospital, and now it's working. But it's also true that the beginning is not easy. You need to invest time. You need to have to invest a little bit money, and then you can start. But the money is not as much. You don't need a very expensive IT platform. You can work, for example, with RedCap or something like that. And there are always more and more doctors or nurses who are really able to work with those IT platforms and create questionnaires by yourself. So it not necessarily has to be very expensive. You can start with, and you don't need, for example, need disease-specific questionnaires. You can also start with generic PROMs, with quality of life PROMs. That has also advantages for our patients.
Yeah, thank you, Florian. Marta, what are your recommendations for the ones that are starting?
Well, we have to engage the persons to do this kind of methodology. And if we start to share the results of our work with all the persons involved, they will engage. When we started to map the pathway of the lung cancer patient, we have discovered some things that we could improve in this mapping. And when the clinicians were told about the results, they were eager to improve them. And so the mapping that initially seems to be a burden and a lot of work, then with the results that we find, the clinicians and all the nurses and the other staff wanted to improve our results. And so the sharing of the work and the results, it's very important to engage all the other persons in this project.
Well, thank you so much. The second level, it's I believe that Ellie Barbel is comment on that in our chat box. And what are the major barriers that you faced, Florian?
Well, in a hospital with different areas, there are always colleagues, guys who are not impressed by such a project. They only see, okay, it's much more work, leave me alone. So, and that's the most important barrier for me. You need support by the leading services of the hospital, by the CEO, the presidents of the hospital, and the leading boards. That's important, the first step. And you have to overcome some barriers, but sometimes it's better to say, okay, if you're not interested, we don't have to implement it in your area. So you have to search for those areas, doctors, nurses, where there is interest. And that's why I say it's better if it's a bottom-up project where you have interested colleagues, partners to implement and to start with PROMs. And the second barrier is the IT platform. I think today you should not start with paper pencil. Don't do it. You should just from the beginning collect data only on the digital way. And for that, you need a platform which is user-friendly for patients. But that's the second barrier. If you use a professional platform, there are different platforms on the market. You have to pay something. And that's a question, who pays for that and how do you get this project reimbursed? That is not easy. Our example was we stopped the satisfaction questionnaire, or a regular satisfaction questionnaire from our patients. We asked every patient and we sent a letter after discharge. And now we ask only in 2 months the patients, and the other 10 months of a year we don't ask. And the money we spared for that, we put into buying a platform, investing in a development partnership with, in our example, Heartbeat. These were the greatest barriers for us.
Great, thank you, Florian. Marta, what were the biggest barriers that you faced?
They were similar as Florian. It's difficult to implement where the physicians and the other personnel doesn't want to get involved. And so this was the main reason to start with lung cancer. I was the lung cancer physician at that time, in time. Now I'm in the medical board. And so I'm trying to diffuse to other kinds of pathologies, but it's not easy to engage everywhere.
Now you need to find another Marta.
Yeah.
Probably a twin. I need to train a twin, maybe. Well, this is quite encouraging. We are almost finishing our time together. What is your vision for value-based healthcare, and what are the steps that you want, the next steps for your organizations? Florian.
Sorry. Well, now I made the mistake too. Well, I think my vision is that we can show that it's really possible, and I'm sure about that you can increase quality and you can reduce misuse and especially overuse of medicine, what is not really necessary for patients. Those things what patients don't really need or don't want. And I think that's my main vision for future. And if you can reduce miss and overuse, you will spare money, a lot of money. And on the other hand, we learn what really matters for patients in daily life. And I think this is the most important lesson we have to learn, because everybody talks about patient-centeredness. And I think 2 weeks ago, I was in a workshop and I heard, come on, there were patients. I don't want to have patient-centered therapy. I want to be a partner in therapy. We want to talk to each other as equals. We want to be on eye level, patient as a partner. And I think the PROM project and the value-based healthcare approach is one step in this direction. And that's my vision.
Thank you so much, Florian. Marta, what's the vision and next steps for the Oncology Institute in Porto?
Well, the next steps are to diffuse this kind of collection of PROMs with other malignancies other than lung cancer. This from the patient's point of view, and then try to use the information that we gathered in the case of lung cancer and speak to the ones that finance our institution in order to get the right price for the work that we do, because it's important, and we managed to achieve a value that it's not the same that we pay, that the costs are, the real costs are for lung cancer patients. And so we also need to work in that field so that we are paid for the right price. And of course, trying to collect what's the best to the patient in order to have the value equation more efficient.
Thank you so much, Dr. Marta Soares, Dr. Florian Rutter. It was an amazing session. I believe that's lots of information here for managers, but also for researchers. From your presentations, I was thinking in lots of research questions that can deal on helping and try to understand how we can implement these projects better across different health professionals. And I encourage also with this annual conference, we have a lot of researchers also attending, and implementing value-based health projects is also an area of interest. And actually it's a flourishing area of not only implementation, but also research. And we can learn a lot together. And maybe in 1 year, we will have lots of results to show. I want to summarize just this session, saying that it is possible to implement value-based projects. We presented 2 cases. For these projects, we have partnerships and long-standing partnerships on the implementation. In this particular case, we had partnerships with Roche Pharma, and it was really relevant to implement and to engage with different partners. And actually, we discuss the barriers and enablers to implement this kind of projects. This is the last session of the day. This was the first day of the European Health Management Annual Conference. It was very fruitful, and I believe at some point some tiring. And maybe we need now this recess to come tomorrow, re-energize for the second and then the third day. So thank you so much, and join us for the plenary session at 10 hours Central European time, 9 hours in Lisbon, tomorrow at the same place, all together. Thank you so much, and see you tomorrow.
Thank you. Bye.
Thank you. Bye.